Hello everyone and welcome to today's Project Launch webinar entitled Addressing the Impacts of Opioid Misuse on Young Children and Families, Resources and Guidance for Project Launch Grantees. I'm Joanne Oshel. I'm the webinar manager for today's session, and I will pass it on to London Losey with the TA Center to get us started.
Thank you, Joanne. Good morning and afternoon to everyone. We're so glad you can join us for today's webinar. We have a brief disclaimer here that's on the screen just to remind you that the views, opinions, and content of today's webinar are not necessarily those of the organizations listed here, so just something to be aware of. And as Joanne mentioned, we are going to start you off with a poll. So our first poll question is, to what extent has the work you're doing through Launch been impacted by opioid misuse in your community? So you'll see the poll coming up, and please take a minute or so to vote. Okay, it looks like most of you have had a chance to respond. So I'm going to end the poll. And the majority of you responded saying that moderately was your response, but some of you say that you are somewhat impacted, and then another 20% or so have said extremely impacted. So I think that the content of today's webinar is obviously really relevant to everything that's happening in your states, and hope that what we present to you today is useful and can be used within your launch program. We have a second poll that we're going to ask. So our second poll question then is, do you have the tools and information you need to respond to opioid misuse in your community? So again, we'll give you a minute or so to respond. Okay, it looks like the majority of you have responded, so I'm going to end this poll too. And in this case, it looks like almost 60% of you said you somewhat have the tools that you need, but you likely are hoping to get some more. 9% said moderately, 6% said a little, and almost 9% said not at all. So thank you for participating in our polls. We'll have one more at the end of the session, but I'm going to keep us moving now, and we'll take a look at the agenda. You previously received an agenda via email, and we have changed it up a little bit just because we feel like we wanted to have the discussion a little bit earlier in the webinar because we really wanted that to feed into the New Hampshire presentation that we have for you, and then to potentially add to it once you've heard from New Hampshire. So we started out with some introductions and logistics, and I'll do a few more in a minute here. Then we'll hear from Jen Oppenheim and Katerina from SAMHSA about some of the work that's being done at the federal level and how it relates to Launch. We'll have our facilitated discussion. Then we'll hear from Liz Lawrence from New Hampshire about some of the work that's been taking place in her state around opioids and how Launch has related to that. And then we can pull in a few more questions and hear a little bit more from all of you before we wrap up. So to give you some faces with names, Jen Oppenheim and Katerina Zubak are from SAMHSA, and they'll be our first two presenters today. Liz Lawrence is our presenter from New Hampshire, and I am London Losey, a Project Launch Technical Assistance Navigator. I serve 5 states within Launch. So what you see here is some of our objectives for today. We're really hoping to highlight some key pieces of information and share resources with you around the topic at hand. We'll be sharing some information that Health and Human Services and SAMHSA efforts that are currently taking place around opioid misuse, and that may include some helpful information for Launch grantees. We'll learn about New Hampshire's approach to the topic. And then we'll also have our discussion, as mentioned. And the objectives that you see here are not necessarily in the order of our agenda, but these are the things that will be taking place today. So with that, I'm going to hand it over to Jen and Katerina to share more with you about what's occurring at the federal level.
Okay, thank you so much, London. And welcome, everyone. We are really eager and excited to start this conversation with the Launch community. We know that many grantees have been feeling the impacts of opioid and other drug use among families in your communities, and our poll bore that out. And we know that many of you have been exploring how you can be part of the solution to this crisis. And we too have spent a lot of time thinking about this and learning about the issue in the last year. So one of our primary goals today is to offer a distillation of some of what we think is the key information related to this issue that we all have and share. A second goal is to offer some thoughts about, and equally importantly, to hear your thoughts about what Launch can do to address this issue. As experts in children's health and development, infant mental health, attachment, parenting, risk and protective factors, we know you have a really critical role to play in helping people recognize the impacts and implications of opioid misuse on young kids and helping early childhood systems to strategically and effectively respond. You all are also experts at building cross-sector collaborations, and this is an issue that truly requires collaboration and pooled efforts across sectors. So I'm going to start with some key facts, and then I'm going to turn it over to Ekaterina, who's going to highlight some resources, as London mentioned. And all of that is intended to lead to a conversation involving all of you about how Launch can play an instrumental role in addressing this crisis. Today will be the beginning of that conversation. But as you're listening, please make a note of areas that you want to learn more about as part of this webinar series, because this is just the first in a series, and we are happy to bring in experts to continue the discussion. And at the end of today's webinar, as London mentioned, we'll be asking for your thoughts about this. And then when we get to the discussion time, just really a plea that you do share some of your experiences and your thoughts and ideas with us. This will raise our collective understanding of the issue, and it will help us direct our efforts in a useful way. So a couple of quick points. First, to underscore something I think we all know, and that is that the issue of children being impacted by substance misuse by parents and caregivers is not new. In fact, it's something that we should be attending to all the time, and some of you are really focused on that. And I'm sorry that it's taken this issue to get us even more focused, but perhaps one silver lining to this crisis is that it's making people stand up and pay attention to the issue of addiction, the inadequacy of the treatment system, the cost to children, families, and communities impacted by substance use. Okay. At the same time, one thing that we found, and some of you may have also noticed, is that most of the attention and the research on opioid misuse that involves women and children appears to be focused on pregnant women and newborns with NAS, or neonatal abstinence syndrome, and the systems that serve these women and babies, like OBGYNs and birthing hospitals. Where there's less literature, definitive research, and guidance is in understanding and addressing the longer-term developmental outcomes and consequences for these babies who are exposed to opioids and other drugs in utero, and for kids who are living in families with opioid misuse. There seems to be a real need for greater consensus and clarity about best practices for early childhood systems supporting young kids and families, including kids who are now in out-of-home care as a result of opioid misuse or overdose deaths. And that's something we really want to focus on in our conversation. So on to some key points. First, it's stating the obvious that opioids are being misused at alarming rates, and this has been on the rise since roughly the mid-1990s as a result in part of changes in medical attention to pain management and aggressive marketing of pain medications like OxyContin and other factors that you all probably have been reading about as we have. And also, just to establish some basics, when talking about opioids, we are referring to a class of drugs that includes the illegal drug heroin, synthetic versions like the extremely potent prescription drug fentanyl, and less potent but very frequently prescribed pain relievers like OxyContin, Vicodin, and morphine. Opioid use among pregnant women is of particular concern because of the impact on the baby's health and development. Unfortunately, these rising rates that we've seen in the general population are matched by those in pregnant women. Between 2000 and 2009, the United States saw a five-fold increase in opioid use in pregnancy. And also important to keep in mind is that many women who are using opioids are polysubstance users. So they may be consuming tobacco, alcohol, cocaine, other prescription drugs. It's hard. I have not been able to find a definitive statistic for polysubstance use, but some estimates are as high as 50% of all users are polysubstance users. And that obviously has implications for developmental outcomes of babies as well. There's some literature supporting the notion that women's motivation to make behavioral changes increases during pregnancy, but it's also the case that many women are unable to access treatment because of lack of available options, cost, stigma, and fear of having the baby removed from a mother's care if she acknowledges drug use. There are a variety of ways that opioid misuse can be treated, but for pregnant women, the current consensus is that medication-assisted treatment, or MAT, is the best practice. So MAT is defined as a combination of medication with behavioral therapies and social supports. And the medications of choice for pregnant women are methadone and buprenorphine. There's a third drug that is used in MAT, naltrexone, but this is not considered to be as safe during pregnancy. So right now, one of HHS's main strategies for addressing the epidemic is to increase the number of prescribers of MAT and the number of patients they can be treating to increase access to drug treatment. But there's another challenge for pregnant women that we thought was really important to highlight, and that is misinformation about the safety of MAT during pregnancy. In many places, women are discouraged from using MAT and are instead encouraged to choose abstinence, and the research is really very clear that this is much riskier for both mom and baby. So one simple way that you all may be able to play a role in your communities is ensuring that medical providers, folks who influence and interact with pregnant women and women themselves are aware of this fact, and that policies in medical facilities and other social service agencies are in line with this information. Because one thing we know is that this is not always the case. As an example, some child welfare agencies do not discriminate between illegal drug use and physician-directed MAT when making custody determinations in families with drug problems, drug issues. So the key point being that there are policies that really influence women's behavior with regard to opioid use. And I wanted to give you this information as another example. The data on this slide indicates some of the ways that states vary in their response to drug use among pregnant women. Under some legislation that Ekaterina is going to talk about in a few minutes, evidence of positive drug use during pregnancy always means at this point that the child welfare system will become involved with the family. But what that involvement looks like really varies across localities and even across hospitals within a given locality. So knowing about the policies in your state or tribe or community is really critical to knowing how best to work with families and provider agencies. And you all as public health and mental health experts and collaborative partners may be able to play a really important role in shaping or implementing some of these policies. And Ekaterina is going to talk about some of the specifics in a few minutes. Between 50 and about 95% of babies who were exposed to opioids in utero, including babies exposed to methadone or buprenorphine, will develop a constellation of symptoms known as NAS or NOWS, which is neonatal opioid withdrawal syndrome. So at this point, hospitals are really still working to get up to speed on having best practice protocols in place for testing for and treating NAS or NOWS. The research literature indicates that hospitals that implement standardized practice protocols related to treating NAS have shortened lengths of stay, and as Ekaterina is going to talk about in a few minutes, there's some definitive and really excellent clinical guidance for hospitals that's going to be forthcoming from SAMHSA really soon, and we will get this information to you. It is information that is very specific to help hospitals and practitioners ensure high-quality care and best practice. And that's really helpful, something that we hope you all will disseminate widely, particularly in remote places, to make sure that this research-based clinical guidance gets out. Research also supports the use of non-pharmacological interventions to reduce the severity of NAS before or in conjunction with medical treatment, which is needed in more moderate to severe cases. So that forthcoming clinical guidance also recommends that hospitals develop individualized NAS management plans that are focused on helping infants self-regulate and also help mothers to understand and respond to their infants' communications sensitively and contingently. So here's a place where the expertise of launch teams can really come into play. Knowing about the additional challenges that these moms and newborns are likely to experience can really help you all shape guidance to NICUs, birthing hospitals, home visiting programs, Part C programs, infant child care. Guidance that really hones in on practices that promote self-regulation and attachment and attend to the psychological needs of moms is really critical. Just as a quick aside, I was at a NIDA meeting last week where a researcher was talking about how vulnerable women with opioid use disorders are to relapse during the postpartum period. That can be a really stressful time for all moms, and if you have moms with particular vulnerability, babies that are harder to soothe, women who are isolated and receiving less interaction with healthcare providers, this can be an even more critical time. So that seemed like an important point to mention, especially as you all are thinking about strategically how support can be offered to new moms and recognizing the increased need in this population. A few quick facts about breastfeeding. Methadone and buprenorphine levels in breast milk are very low and pose little risk to infants, although there are some situations in which a woman on MAT should not breastfeed, or certainly when women are consuming other drugs. At the same time, data suggests that any breastfeeding, however brief, can decrease the infant's need for pharmacological treatment of NAS and will decrease length of hospital stay. So really the key recommendation is to underscore the need for women to be talking with their medical providers about breastfeeding and whether it's indicated. Finally, a few points about older children. So as I mentioned at the beginning, it seems like the most attention to date has been focused on infants, although there are researchers who are looking at longer-term outcomes for children exposed to opioids in utero. And this is actually a priority area for our new Assistant Secretary at SAMHSA. And there's a project underway that will include a literature review on developmental and psychosocial outcomes for children exposed in utero, and an expert panel that's going to be convened this spring with a white paper with recommendations for early childhood providers as one of the outcomes of that meeting. So we will be sharing that information as it unfolds. That meeting also is going to include a dialogue with federal staff, and one of the goals is to produce recommendations for early childhood programs that is really grounded in the current research. So we hope that will be satisfying in the long term, but in the short term, I wanted to underscore a couple of things that we do know that's very relevant to our work in launch. And probably the key one is the increase in out-of-home placements for young kids in recent years after many years of decline, with the highest rates being among children under the age of 1. So there's some really interesting literature emerging about the increasing numbers of kids being raised by grandparents, often outside the formal foster care system. And there's some support and advocacy organizations like Generations United that are really worth learning about. And some interesting legislation, actually, that states are putting forward to support grandparents, including with services like kinship navigators. So this is an interesting topic that we could certainly spend more time on in a subsequent webinar if there's interest. But for the moment, I just wanted to underscore what I think we all know about the challenges that disruption in attachment and placement can create for a young child, and how responding appropriately to these issues can be an important focus for home visiting programs, child care programs, even in primary care. So again, a role that Launch can play in raising awareness about these issues with providers and offering guidance and input with regard to special attention and supports needed by these families. That could be delivered through mental health consultation, integrated care, and family strengthening. So now I'm going to turn it over to Ekaterina, who is going to walk you through some resources, and then we will pause for some questions and some discussion.
Great. Thank you so much, Jen. And hello, everybody. Thank you for joining us for this webinar. So like Jen said, I'm going to sort of breeze through some legislative context just to get us all on the same page in terms of what's been going on in that arena, and then talk about some tools and resources which we hope may be useful to you in your work and partnerships. So first, there's CAPTA and CARA. I'm sure you're well familiar with these acronyms, so I'm going to go fast. CAPTA was passed in 1974 to support activities related to child abuse and neglect, and then was amended in 2003 to include the requirements for the development of a plan of safe care to protect children at risk for maltreatment. This amendment includes the requirement to notify CPS, as Jen has highlighted, when infants are substance exposed prenatally, and for states to have policies for referrals to address the needs of these infants. And then the 2010 reauthorization of CAPTA added additional reporting requirements for the states. I have listed them on the slide if you're interested. And in 2016, the CARA clarified the plans of safe care requirements and importantly required that both the infants and the caregivers' needs be addressed. We really want to hone in on these laws because of the implications they have for systems and communities. Since CPS needs to be notified when infants are exposed in utero, child welfare needs to make determinations for these cases. On one hand, this drives the reluctance for women to seek help and disclose substance use, but on the other hand, there is the requirement of agencies to develop comprehensive plans of support for the infant and the mother. What we are hearing now is that there are challenges with the implementation of these plans, and we encourage you to explore how this is being rolled out and implemented in your communities, and what can be done to make sure the plans of safe care are actually beneficial to the families involved. So then there is the Protecting Our Infants Act. It's a bipartisan legislation that was signed into law in 2015 to respond to the unmet needs of pregnant women and their newborns after national rates of infants with drug withdrawal symptoms increased fivefold in a span of 10 to 12 years. The HHS Behavioral Health Coordinating Council Subcommittee on Prescription Drug Abuse developed the POIA report to Congress and the final strategy, both available online. These documents include thorough background information on prenatal opioid exposure and NAS, and a list of HHS efforts to address the issue. We think that reviewing this document may be useful as it outlines recommendations for the federal government on how to address NAS and opioid use. And these recommendations could also be relevant to state or tribal efforts. Several recommendations align with the work you are doing. So for example, screening for opioid use disorders for women of childbearing age, and increasing knowledge of providers who work with infants with NAS, and provision of family-friendly and coordinated treatment and recovery supports. Some more details can be found online, and also HHS right now has convened an interagency work group to align federal efforts and avoid duplication, and we have been involved in representing the early childhood realm. Just a quick reminder of some of the SAMHSA grants that are available in communities and are addressing the needs of children and families affected by substance abuse. So you guys know, for example, in the block grants, monies can be set aside to address the needs of families. And then there's the medication-assisted treatment grants, which actually include a particular focus on racial and ethnic minority groups, and some other examples of subpopulations that are being targeted with these grants include pregnant and parenting women in rural communities. There's also the Expanded Substance Abuse Treatment and Family Drug Court grants, which you might be familiar with, and several of the requirements align well with the work of Project Launch again, and could create new opportunities for collaboration. The grant requirement language highlights the impact that parental substance use may have on young children's development, including social-emotional development. And the grant activities can focus on providing strategies to strengthen the parent and child bond, and provide services such as home visits, and providing wraparound supports that facilitate recovery of the parents, such as child care, vocational, educational, and transportation services. Finally, last but not least, is the PPW program. There's lots of resources on the link listed on the slide. That's their TA Center, and those resources could actually be really beneficial in your work. The purpose of this program is to expand treatment, prevention, and recovery for women and their children in residential substance use treatment facilities. And this includes services for non-residential family members and partners for the women and the children. And again, SAMHSA has identified traditionally underserved populations, especially racial and ethnic minority women, as a population of focus for this program, and particularly African American women because of the high morbidity and mortality rates of pregnant women and their infants in this group. There have been great collaborations between the PPW and Project Launch grantees in the past, so we can share some examples of that if you're interested. We really encourage you to find out who is implementing these activities and where there may be gaps in early childhood and mental health expertise which you possess. For example, are there treatment facilities in your area that accept mothers and newborns, and how can you connect your families who may need these services? Or are there substance abuse treatment services that are court-ordered? Are these services able to address the needs of young children and their families in a holistic, comprehensive manner? However, the biggest influx of money focused on opioids is through the recently awarded state targeted response grants, where up to $1 billion has been awarded to all states and territories over the course of 2 years. The funding goes to states and is also able and supposed to cover services in tribal communities. Many of the states have selected pregnant and postpartum women as one of their priorities. And we really encourage you to connect with the single state authorities overseeing these funds and discuss collaboration possibilities. As the states are expanding access to MAT, how are the families of young children being supported? And since we know that in order to support the recovery of parenting women, we must also address the needs of their children, where are there gaps in getting these women into successful treatment and preventing relapse? Our partners overseeing the SDR grants at SAMHSA have been really helpful to us and have pointed us to the women's service networks as a possible opportunity to increase focus on the services and supports for pregnant and postpartum women. So we think that this could be a good opportunity, again, for you to collaborate at the state level and that these networks would be the most amenable to address the needs of the populations you are serving. And so one other wonderful resource I wanted to highlight is the NCSAW, so the National Center on Substance Abuse and Child Welfare. This is a collaboration between SAMHSA and ACF, and it provides expertise to child welfare and substance use professionals. The website you see listed offers a plethora of resources, including some excellent webinars on the topic we're discussing today. There is lots of info for child welfare workers, but also useful contextual information on opioids and young child systems. And if there is interest, we could have someone from the TA Center present in the future. So you see that one of the specific resources I wanted to highlight is the collaborative guide or toolkit to the treatment of pregnant women with opioid use disorders. This guide is available online fully and has been a great source of information to us as well. It really offers a concise summary of best practices and great background information. This guide could be shared with your partners or used as an approach towards cross-system and cross-service efforts. One thing that really jumped at us when we reviewed this toolkit is that it lays out the role for many child-serving systems, but really amid some key early childhood players that we are usually working with, such as home visiting programs and early care and education. This in itself speaks to the need for more information sharing and widening the circle of partners. It also provides a really great and interesting case study from Vermont, and we suggest you review it and think of how it could be useful in your collaborative efforts. Another great resource that Jen alluded to that will be forthcoming is the clinical guide for the care of pregnant and parenting women with opioid use disorders. For now, the report is available online. It was prepared by CSAT and SAMHSA. The link is right there on the slide. The main goal of this report was really to create practice-focused, detailed, comprehensive guidance for the treatment of pregnant and parenting women with opioid use disorders and their infants. It used a very rigorous methodology to come to consensus on best clinical practices. You can find the detailed recommendations online, but a final guide and report with fact sheets and sort of guidelines for practitioners will be released soon, and we will send it out to you when it's published. We cannot emphasize enough about how wonderful this resource has been in increasing our knowledge on this topic, and we hope that you find it beneficial as well. So what I've done is I've extracted some recommendations that would be of most interest to you. I'm not going to go through them all, but again, wanted to suggest that the content of this document and forthcoming guidance could be useful to you in sharing best clinical practices. And there's also some tribally specific resources I wanted to highlight. For example, a few years ago, we worked with ACF to release, Administration for Children and Families, to release a policy statement for tribal communities. And it contains lots of great examples of what some tribal communities have implemented to support young children and their families. The entire document is available online and could be a useful tool for Native communities in structuring the services and efforts to support your families. And probably at this point, we're out of time and you are experiencing PowerPoint overload, so I'm just going to go really fast through this last slide. Another list of resources from a variety of sources really offers great background information that you might find helpful. We have been sharing this guidance here and there with different sites, with our partners, and it has really increased our own knowledge of this issue. And I think now we're going to open up the lines for questions.
Thanks, Ekaterina. Reminder, everyone, that if you are wanting to write down all those resources, you don't need to. There's a copy of the presentation in the file pod on the left. So please look there and download that for your own records. And are there any questions for Ekaterina and Jen? Everyone's so quiet. If you have questions, you can also enter them in the chat window, and I'm happy to read those out for anyone who may be feeling shy at the moment.
And London, if we don't have any questions, we can move on.
Yes, that sounds good. It doesn't look like we have anything at this time, but we'll come back to questions later on too. So if something comes up for you all later, we can circle back to that.
Okay. So what we wanted to do at this point, and prior to having a conversation with all of you, is to share some ideas that we have about how launch grantees might be able to contribute to addressing this issue. And we wanted to put these all up on the screen and give you a few minutes to walk through them or to read them. We can walk through them, but thought that our time might be better spent giving you the opportunity to share with each other and with us some of your experiences and challenges or your reactions to these ideas. And then, as London mentioned, we can have some discussion, and then we'll go on and hear from Liz about some of the challenges and solutions in New Hampshire. We have a lot of people on the call today, so I'm sure we don't have time for 60 people to speak, but we hope that someone out there is willing to be the first to share something about what you're seeing, how you are thinking about how launch can be a part of this solution, or some challenge that you're having.
Okay, so we'll just pause here and let you read through some of these suggestions we have highlighted on the slides. So for example, as you're thinking about your screening work, could efforts to increase the use of adverts be strengthened? And as you look at your cross-system efforts, you could map out new strategies that involve the dissemination of best practices of care or education around the needs of young children impacted by substance use.
Or if you have thoughts about any of the resources that we talked about, and whether if you've used any of them or if they sound like they would be useful to you.
Well, maybe there's some things that we missed that you would like to share with everybody else in the launch community. Or we might just call on you. Joking. We're joking.
So I think just to clarify, London, people's lines are unmuted, right? So some brave person could speak up or type in the chat box or raise a hand and be called.
All of those are options for our audience today.
I wonder if they're plugging in around the reservation. If that's their target audience, you know, if that's where the states decided to funnel the money.
Could you repeat the beginning of your question, because we could not hear the beginning?
And maybe actually if people want to say which grantee they're calling from or your name, you don't have to. Was there a question? I think there was one, but we just couldn't hear the whole thing.
It sounded like it was maybe around funding.
So the way I heard something about funding from states to reservation communities. Is that correct? So I guess we can answer to the best of our ability. In terms of the STR funding, it's up to the states on how to distribute the funds. And they should be providing supports and services to populations residing on tribal reservations and sort of making sure that there's access to treatment for those communities as well. And there has been conversations at the federal level on how to address support for tribal communities.
Mm-hmm.
Well, we can certainly move on, and Liz has a wonderful presentation, and then we can open the lines up again for conversation or questions after Liz's presentation. This may be too big a group to have this kind of conversation, but please let us know if in fact you want to have a forum for sharing what you are doing or some of the challenges, because we really would like to hear. We'd like to be able to harness our efforts to give you what would be helpful to you in doing your work. So it doesn't have to be on this webinar, but please take the time to share thoughts if you want to give us any of that input.
And this is London. I think it's important when we look at launch that we think about the work and what launch brings to it, how it has that social emotional lens, and the way launch coordinates care across systems and takes that kind of systems approach. And so thinking about who you're partnering with and how different aspects of launch come in really apply here. And so it was mentioned what our discussions questions are, and I'm going to put them up on the screen here, and then we can go back to that slide. But it was about what potential solutions have you explored to address misuse in your community or communities. And that could be something at a small level, just, you know, maybe you're just starting to talk about this, but you have some small successes that are taking place, even if they're just the start of conversations. Or something bigger, which we'll hear a little bit about of what's happened in New Hampshire. And then some of the challenges that you've had. Undoubtedly there are challenges out there, and probably they're not necessarily unique to one state or another, but they might be. And so hearing what those are and sharing with one another so we can learn from one another's experience. There is a question in the chat from Christina, and she's curious to hear about how states plan to continue services to children and families at the end of the grant period. So what are some thoughts from other launch grantees on the line there? Okay. Oh, Christine is entering a little bit more, so I'll give her one more minute there to finish typing, and then we can maybe move on and come back to our discussion as you have some more time to think about it.
And I guess as we're waiting for Christina to type and for anybody else to provide input, you know, I think what would be useful to us at the federal level is to hear what would be helpful for you in terms of discussion, in terms of resources, in terms of information exchange. This is an issue we're hearing about a lot on our grantee calls, and I know you are as alarmed as we are. There's a lot of very complex factors, and so we're hoping we can put our minds together and join efforts.
So for those of you who maybe want to connect with Christina in response to her question there, she's saying that she'd be happy to connect offline as well. So thank you for that, Christina. I think we will move on to Liz's presentation, and then we can come back more to our discussion, and hopefully that'll allow you some time to think more about some questions and to think of more what's happening in your state to share with one another. So Liz,
Greetings, everyone. I want to thank you and welcome you again for attending. And my hope today is that I can increase ideas and tools to help you with the opioid burden through Project Launch and just some other ideas that you may gather from the state of New Hampshire. To begin with, I really want to thank my Project Launch New Hampshire colleagues, both from past and present, for their continuous hard work and support on Project Launch, in particular the Project Launch management team, Laura Milliken from the Director of Spark New Hampshire, the Governor's Early Childhood Advisory Council, Lara Quiroga, the Young Child Wellness Coordinator and Director of the local Project Launch at the Manchester Community Health Center. I also want to thank my colleagues at Maternal and Child Health and my supervisor, Rhonda Siegel, the administrator of Maternal and Child Health. I also want to thank past Project Launch folks, including Carol Garhart and Deirdre Dunn-Tierney, who moved over to New Hampshire Special Medical Services. So this is a really full presentation today, as so much has happened in New Hampshire in the past 2 years. I'll be sharing a lot of information, statistics, and details, and I will do my best at capturing all of it. I also have provided a supplemental resource packet for you that captures additional information, and you have my email on the slide there, so you're welcome to email me if your questions don't get answered in this presentation. So since 2015, New Hampshire has been experiencing one of the worst public health challenges in its history. So what happened, what is New Hampshire doing, and how has this intersected with Project Launch? These are some of the goals that I hope to answer for you today. To begin with, I want to share a bit of the data story that led up to where New Hampshire is now. By 2005, more and more New Hampshire residents were trying heroin. Also, at this time, prescription opioids were being prescribed more and more by physicians. And by 2011, illicit drug use among teenagers were higher in New Hampshire than in any other state in the country. Illegal or stolen prescription opioids, spice, bath salts, and meth were some of the other examples. Since 2007, the number of New Hampshire residents admitted to state-funded treatment programs today has risen 90% for heroin use and 500% for prescription opioid use. And during the same period of time, as Jen alluded to earlier, during the epidemic, the neonatal abstinence syndrome increased as well. In this New Hampshire hospital discharge data slide, the New Hampshire birth rate per 1,000 births is indicated on the left-hand axis, and the number of discharges are indicated on the right-hand axis. The blue bar represents the discharge per rate per 1,000 for babies born with NAS with Medicaid insurance, and the blue line is the number of births from Medicaid. The green bar and the line represent babies born with other payers, other insurance, or self-payers. So the point I really want to make, and that is quite obvious, is that the Medicaid population in blue has had a higher number of babies born with NAS and a steeper increase than the population with other insured. And this is an 11-year period from 2000 to 2011. In 2015, New Hampshire had hit its worst year yet with 439 drug-related deaths, 397 of them caused by opioids. But 2012 proved that the epidemic was still not subsiding at all, with 477 drug-related deaths, with 385 caused by opioids. With 39 deaths per 100,000 residents among states, New Hampshire had the third highest rate of drug fatalities in 2016. The shining light that I want to point out during these 2 years, however, was the beginning of saving lives through Narcan administrations, and there are certainly many of them if you look at the slide during 2015 and 2016. So what did New Hampshire do to respond to this crisis? There was obviously a lot going on in a lot of industries and groups of people. So basically New Hampshire utilized cross-cutting collaborations, and the priority was at that point to save lives. New Hampshire came together with collaborations that included the Governor's Commission on Drug and Alcohol Abuse and Prevention, and the many task forces that it has, state agencies, nonprofit organizations, local fire and police, cities and towns, volunteers, and that's just to name a few. These collaborations created dynamic strategies to mitigate the epidemic, including creating legislation, increasing substance use disorder capacity, increasing access to care, public safety measures, creating multiple workforce initiatives and training, public awareness campaigns, and increasing early intervention programs, just to name a few. I just also want to point out that New Hampshire expanded Medicaid through the ACA in 2014, and New Hampshire Medicaid has been paying for substance use treatment and drug court programs in New Hampshire since this time. This had an impact on the epidemic as it increased insurance coverages for residents by 70,000, and there were many graduates of the drug court programs who are now back at work. So again, immediately saving lives was the priority, and to do that, in 2015, 2 laws were passed. One was allowed for New Hampshire to purchase naloxone kits for administration, and the second law was the Good Samaritan Law to protect victims and witnesses from arrest and prosecution for possession or use of illegal drugs. Then the Department of Safety provided a statewide train-the-trainer to police and fire personnel to carry and administer intranasal naloxone. The City of Manchester's efforts with naloxone will be covered later in this presentation. Right now I'm just focusing on the statewide efforts. The first 7 months of 2016, the legislature and governor enacted approximately 15 bills. The governor and executive council then approved 20 statewide vendor contracts for SUD services, totaling $24 million approximately. These consisted of state and federal funds. So as alluded to earlier, SAMHSA has a block grant, and the Bureau of Drug and Alcohol Services at New Hampshire, beginning in 2016, offered these comprehensive services. As you can see, they were services that were mentioned earlier, such as medication-assisted treatment, ambulatory withdrawal management, medically monitored inpatient withdrawal management, outpatient intensive outpatient partial hospitalization, low-intensity residential at 90 days, high-intensity residential at 28 days, high-intensity residential for pregnant and postpartum women, including transitional living, recovery support services, transitional and child care. Again, in 2016 as well, the Bureau of Drug and Alcohol Services contracted with one vendor organizer to develop a network of peer recoveries across 5 regions of the state, and the 5 public health networks across these states are currently helping fund those initiatives, as well as emergency preparedness. In 2017, contracts from the Bureau of Drug and Alcohol Services went out to vendors, included integrated Medicaid assisted treatment, as spoken earlier, for pregnant and postpartum women, intensive outpatient, parenting and well child education, community-based services, recovery support services with SUD, delivery, obstetric, pediatric, and primary care. Again, I think you heard earlier a couple times the state targeted response from SAMHSA funding. In 2017, that included integrated medical assisted treatment for pregnant women, naloxone distribution to individuals transitioning from corrections to the community, and that was for women as well as men. The reentry care coordination for women transitioning from corrections to communities. Recovering support services and parenting programs for pregnant women and parents in recovery. Recovery support services for regional access points, and targeted prevention programming for DCYF-involved families with SUD. Another form of funding that the New Hampshire Bureau of Drug and Alcohol Services has received from SAMHSA is the State Youth Treatment Planning Grant that helps state agencies collaborate and plan for the substance misuse needs of children, youth, and youth transitioning out of high school. It includes workforce development for the different age ranges, financial mapping for all services that include juvenile justice accountable block grant, Title 4E, including and hopefully Children's Health Insurance Program, CHIP, and we have yet to see that. We're all hoping for that. So switching over to another state agency and what DHHS Division of Public Health Services has done. This particularly is in the section that I work, maternal and child health section. Some examples are some programs. 2000 to the present, the Maternal Infant Early Childhood Home Visiting Program, otherwise known as MCV, is HRSA funded. The MCV program staff have been trained in motivational interviewing, which is an evidence-based method to using and treating persons with substance use disorder. MCV also screens for substances, depression, using the SBIRT. I'll also go over strategies for Project Launch in a little bit. Maternal and Child Health used HRSA funding, Early Childhood Comprehensive Services, to partially support statewide training for early childhood providers, teachers, and mental health professionals in trauma-informed early childhood services and training to increase knowledge of the providers during the first 2 years of this grant. Then to help sustain the initiative, and spread trauma-informed care knowledge even further throughout the state, it offered a train-the-trainer training, that's a mouthful, and a highly qualified trainer cohort that included monthly training and technical assistance from a trainer and consultant, and cost-free services to children and parents / caregivers throughout New Hampshire in early childhood education and school-based settings. Also, Division of Public Health at Maternal and Child Health Section. In 2016, we hired an opioid data coordinator to enhance the data collection by collecting real-time data on neonatal abstinence syndrome in all New Hampshire hospitals. That person also coordinates and provides opioid surveillance data to the Governor's Commission on Alcohol and Drug Abuse Prevention, Treatment and Recovery, and the statewide naloxone distribution and training initiative. Maternal and Child Health requires all community health centers with primary care contracts to use the SBIRT, which is a screening for SUD, and partially funds a position at the Department of Justice that coordinates the National Violent Deaths Reporting System in New Hampshire. The system encompasses unidentified data and summaries on broad categories of deaths, including opioids and undetermined deaths. In July of 2016, the Division of Public Health Services, the Division of Child, Youth, and Families, hospitals, providers, and the New Hampshire Governor's Commission on Alcohol Perinatal Task Force proposed a plan to help keep newborns safe. The plan is designed to ensure infants born with neonatal abstinence syndrome or other symptoms of drug exposure, withdrawal, or the caregiver families to receive adequate and appropriate services so all infants born affected with substance abuse systems are protected and treated. A questionnaire is introduced to the mother at the onset of prenatal care or as soon as the exposure is for harmful substances. And the plan must be completed by the parent and guardian upon positive results of the substance, as well as the caregiver. A new strategy to this plan is going to be piloted soon. Division of Public Health will obtain data on babies exposed to opioids from the birth certificate. It'll be a new field of data, and then that field will be assigned a number to the certificate. Health providers will have safe plans of care with every baby exposed. However, as alluded to earlier, in New Hampshire, not all babies exposed to opioids are reported to DCYF and to women who have plans. Only babies that providers are really concerned about for their safety will be reported as standard law. Division of Public Health Services will report aggregate numbers to DCYF yearly. In 2017, the Department of Safety applied for and received SAMHSA funding through the First Responders Comprehensive Addiction Recovery Act funds. It will be used to increase the availability of naloxone and devices for emergency treatment of an opioid overdose by first responders statewide and a person at risk and their support system. It also provides training on the use of medications and devices and facilitate a first responder referral process to the New Hampshire Crisis and Regional Access Services, providing a single regional point of contact to facilitate and follow up with treatment and recovery programs. The follow-up portion of this program is a great prevention strategy for repeating overdoses. At the Department of Education, multiple programs have been running since 2013, again with most of them with SAMHSA funding. All of these programs have very important system building, social emotional development, behavioral health outcomes in children and youth, reducing the prevalence of alcohol and drug use among school-aged children, and professional development. The SBDEG, otherwise known as the Supporting Professional Development Education Grant, supports increasing capacity for New Hampshire as a pyramid model state for more information on the Pyramid Model Consortium. I will talk a little bit more later with the Project Launch strategy, but you can also look at the supplemental resource that I handed out with this presentation. And then last year in 2017, the DOE received Family and Systems Together Fast Forward for Children and Youth 2020. And this will support the expansion and sustainability of state-level systems of care for children, youth, and their families. So I have only 10 minutes about to continue on with sharing some programs, but I'm going to start flying through a few slides here. So I wanted to give an example, and it's called Moms in Recovery, and it's run through Dartmouth-Hitchcock Medical Center. I had the privilege of seeing this program presented. As a board member of the New Hampshire Association of Infant Mental Health, we had a Moms in Recovery presentation at our annual meeting last year. The program has multiple funders, and according to New Hampshire hospital birth data, Dartmouth-Hitchcock had, at that time, the highest rate of neonatal abstinence discharges at 266, and that's about 7.6%, which at the time was the highest in the state. So just some details on the program. The director is Julia Frew, MD, founded in 2013. Fully integrated for pregnant women and postpartum women with opioid use disorder and their children. Trauma-informed and friendly model. It served 110 women to date. They room mothers and babies together for maximum skin-to-skin contact, and encourages breastfeeding unless that's contraindicated, as was talked about earlier. It's also changing the way hospitals approach to infants at risk. Cared for in the pediatric unit, not the NICU. Rooming in with the mother, which I said earlier was increases in skin-to-skin contact. Prenatal family education. Encourages breastfeeding unless contraindicated. Again, I repeated that. Some early outcomes. Average length of stay has decreased by 4.6 days. Medication use has decreased from 46% of at-risk infants to 27%. And you can take a look here at the improvement over time in the two cohorts in 2014 to 2017. Longer gestation period, an increase in the mean birth weight, a decrease of the infant length of stay in the program, and a decrease in DCYF involvement. Some takeaways from the program. Women are really motivated to care for their babies, their unborn babies, and protect their pregnancies. Emerging data shows association exists for pregnant women and treatment, and this relationship should be acknowledged. Integrated programs facilitate trust through continuity of providers and communication across disciplines. Co-located care promotes engagement in both prenatal care and treatment. And integrating psychiatric care enables healing of both addiction and its antecedents. Okay, so now for Project Launch. Right now you're looking at the city of Manchester, where the project is located. Manchester is the biggest city, actually in northern New England, with a population at 110,000. And if you just read down there, you can just get an idea of the service population. It is a refugee relocation community, and that has increased a lot from 2008 to 2014. 80 dialects are spoken in schools. There's a high single women on Medicaid rate, and 50% of the children or more are eligible for the National School Lunch Program. So I'm going to skip over this slide because you can look at it after. But these are every Project Launch grantee has to focus on 5 strategies. I'm going to let you look at that after, and I'll move on in the effort of time to focus on what we've been doing in each strategy and examples of how each strategy or some of our strategies have worked with the opioid burden. And I'll give you one example of a lesson learned and how we tried to find a solution and did. So integrating behavioral health into primary care, Manchester Community Health Center has 1 care coordinator and 3 community health workers. You can refer to your packet to review all of the screenings that they provide. They are screening for children using ASQs and ASQs SEs. They screen parents using SBIRT and the Strengthening Families Protective Factor Survey. They develop a plan of care with families and assist in assessing services and overcoming barriers, and serve as bilingual communities. One of the successes of this strategy is creating access to this service at multiple entry points. So for example, if a parent or a child is the initial patient, and then upon further investigation, the CHW notices that a screening may be needed for the adult or the parent or caregiver, that's another way that they can enter in, and it becomes seamless. Another strategy success is behavioral health support coaches for teaching in early childhood classrooms, known on the strategy as mental health consultation and ECE. That is what New Hampshire chose to do. Again, the Pyramid Model Consortium, formerly known as the Social Emotional Foundations for Learning, is the basis for this work. Project Launch is working intentionally with them, the Pyramid Model Consortium, to provide train-the-trainers for TPOT, the Teaching Observation Tool for preschool ages, Tippy Toes, the Pyramid Infant Toddler Observation Scale, and Positive Solutions for Families to create high-quality statewide early childhood infrastructure. The Positive Solutions for Families is a parenting program. That is what we chose for our research-based parenting program, and that's part of the other strategy, which is family strengthening. Again, you can look at the packet that I sent to look at all that we do for this strategy. So coaches work with teachers to create supportive environments through effective teaching strategies, identifying the means of behavior, and creating and implementing behavior support plans for children. This increases the ability of programs and teachers to manage challenging behaviors in the classrooms, settings, and improve knowledge of social emotional development and decrease preschool expulsion. So one example of a challenge that we had in one of our strategies is, I referred to the Positive Solutions for Families earlier, and while our facilitator was facilitating the parent program, the parent came in under the influence, and the facilitator had to report this to the police and DCYF. And that was really stressful on everybody, including, and most importantly, the other participants and the parent and the child. It was very disruptive. So what came out of that was a lot of discussion among the Project Launch staff, leadership, local council, and they came up with two new policies. One was with the actual program, and if a parent or a participant came to the program under the influence at the parenting class, they had to agree to be in active substance abuse treatment in order to participate. And then the second, at Manchester Community Health Center, in their patient policy, patients who presented at any services there 2 or more times in an impaired state needed to actively participate in drug and alcohol treatment and counseling in order for them to continue access of care. Okay, I've been told I only have 2 minutes, so I'm going to fly through this. Again, you have lots of information if I miss some things. But basically, one thing that came out of Project Launch was the need to access other programs and children who are not getting treated. So the adverse childhood experience was the result of a Project Launch Manchester Police Department and YWCA collaboration. And basically, we had the idea of bringing partners together to create a model that would identify children that were exposed to trauma during police calls but not getting treated, and then give the children access to treatment. The collaboration formally came together in 2015, and then in 2016 applied for a 3-year grant from a New Hampshire foundation and began with the grant in May of 2016. And then Project Launch was a part of training behavioral health workers and police officers in trauma-informed care for early childhood services. And so what is ACERT, you may be asking at this point? So basically, after a domestic violence call at a home is cleared by the Manchester PD, the PD dispatches the ACERT team, which consists of an officer, crisis service advocate, and behavioral health specialist, to speak with the child and the parent in a trauma-informed approach. And the hope is that the parent will sign a release for the child to be referred to an agency of their choice for services, the one that best matches the child's needs. This is the quick flow because I'm running out of time. Some takeaways are initially predictive policing data for domestic violence and overdose used to assign 2 shifts per week, but the overdose calls were too unpredictable, so now the predictive policing is only used for domestic violence calls. During ACERT shifts, officers spend time following up with families who have had overdose calls, and trauma-informed training is helpful for first responders. So, I am told that I am supposed to wrap up. However, I want you to just look at this slide, and because I told you I would talk about Manchester Fire Department, because you can't talk about the opioid burden in New Hampshire and Manchester without talking about the Manchester Fire Department. So I'm getting told that I have to wrap up, but please look at this slide and see how many lives were saved, and go to the website to look at more information for Manchester Fire Department. Thank you, everybody.
Thank you, Liz. We have a couple of questions. Kate has asked in the chat if the financial map is available to share with other states.
That is a possibility. I would have to ask the Bureau of Drug and Alcohol Treatment. I can't answer that definitively yet.
Okay, if that does become available, we can possibly share that when we send out the recording link. And then Laura has noted in the chat that there's a quick update from just minutes ago that Safe Stations just went over 3,000, the number of requests for recovery help.
Excellent.
Regina Flynn, you had your hand raised before. Did you have a question? And while we wait for Regina, if we're going to open your lines again to have a bit more discussion, we have a few more minutes left so that we can maybe come back to our discussion questions, and then we'll wrap up with a bit of polling. So we'll unmute your lines, and let's try to get a little bit more conversation going if we can. Are there any other questions for Liz? So what about our discussion questions? Thinking back on the discussion questions that we proposed earlier about some of the solutions and or challenges that you've experienced in your states, have you had some time to think a little bit more about those? And do you have any other thoughts to share with us? Some things that came to mind for me, or maybe some work you've been doing around plans of safe care or systems of care, maybe some work that you've done with screening parents, either during well child visits or outside of those. Any guidances or policies that have been developed, either at state or local level, maybe specific to the pregnant and parenting population, but families more broadly? Terry has entered in the chat that the lack of follow-up care is a major issue. Thank you for that. Any other questions or thoughts around our discussion question? Oh, Laura says it's also important to stress that their work has also focused on the importance of prevention and increasing public awareness around adverse childhood experiences, particularly given that they lead to increased risk for opioid use later in adolescence and adulthood. Just thank you for that. Whitney has said that inadequate inpatient treatment options are a big challenge. Any others?
London, there were a few questions before Laura's, and then it looks like there's a couple others as well.
Yes, I see the one around the financial map and Regina's question. Oh, Regina is wondering, are you able to get the hospital charge data in real time? I think that's to your presentation, Liz. So, Liz, did you have a response to Regina's question there?
Yes. For neonatal NAS, there is real time, but I think I'm seeing Regina saying the real time with Project Launch, and so no, not for Project Launch.
Terry has said our state is cutting services. How can we get funding for help? Jen and Ekaterina, do you want to tackle this one?
Sure. Yeah. Well, that's a hard one, isn't it? I think that the main strategy, or one of the strategies, certainly, and one of the points that Ekaterina made, is just to be working with folks at the state level to try to make them aware of the issues and what you're seeing in your communities and what some of the needs are. So sharing data like what Liz had from the local level, and then really trying to advocate for what, either for funding, although we know that's really hard in this current environment, or, you know, for getting a piece of the pie devoted to the needs of kids and families, knowing what those are, and knowing, as others don't always, aren't always as aware as you all are, about the impacts on kids and how this, you know, has long-term consequences for kids functioning, and framing that in terms of school achievement and later health outcomes and return on investment.
And Terry, I'm not sure which community you're from. I haven't met you before, but I think maybe connecting with a few of the other states and communities that are experiencing similar cuts. I think this is a story that we hear a lot from a variety of places, and there's been some strategies developed. Sometimes successful, sometimes they take a while and they're not as successful, unfortunately, to sort of fill the gaps in financial support. I think leveraging the family voice to sort of, like Jen was saying, educate about the needs of the families and sort of the impact.
And then the other thing, I think, our thinking in presenting some of the information about other funding streams, grants, although they are time limited, some of the other SAMHSA grants was, and including the block grants, is there a way to siphon off some of that funding as well, or have that funding be inclusive of the things that you all are seeing the need for, and the children and families that you serve?
So in the interest of time, I think we need to start to wrap up, and I'm so glad we started to generate this conversation. There are a few more comments and questions in the chat. I'll just read those really quickly, and then we'll move on to our final polls. Regina made a comment that states can get lists of providers that are prescribing buprenorphine and reach out to those to see if they are interested in working with Project Launch. So I'll read those to you as we go here, and you can start to respond to your poll.
Mm-hmm. Oh, and I was just going to say that's something we can absolutely look into. So we'll follow up on that question or request.
Diane has said for early supports and services programs, there has been a large increase in referrals, many of which are hard to find families and get them into services. And Sharon is wondering about the potential for intervention with young children of parents using safe injection sites. purely hypothetical at this point, but a potential opportunity for collaboration in the not too distant future. So she's trying to learn more about what others have done. So that's something we can follow up on as well.
That's something we've been hearing about as well and really interested in, so that's a great thing for us to include on a future webinar. So thank you. Thanks for reading that out.
Yes, thank you. So now if you'll look at your screen, we have another poll. We have 2 more polls for you. This first one is asking what type of support would be helpful for you to receive as a launch grantee to further your understanding of opioid misuse and efforts to address it. So this is an open-ended question, so please just type in your thoughts here, and then we'll move on to our final question. So as people start to respond, I'll let you know some of the responses we're seeing related to looking for some resources in Spanish and expansion grants, if there are possibility to continue and expand the work that has begun in this area. And we'll leave that poll open for just a few more seconds. Recommendations around anti-stigma campaigns, funding to do work in early childhood, more support around clinical interventions and funding opportunities, data research on best practices for working with young parents and children impacted by opioid misuse. These are all great things that we can start to incorporate into future webinars in our series as well. So thank you. Okay, I'm going to end this poll, but if you didn't have a chance to respond, you can answer your response in the chat. And our final polling question here is to please state your preference for future webinars in this series about how we conduct the discussion and presentation. So your options are to, you would like discussion time at the end of the webinar for more in-depth discussion around the topics being presented. You would like to only have experts presenting and no discussion. You would like to have a discussion time that's separate from the webinar, or you do not have a preference.
And London, maybe we could also, while people are, or when they complete this poll, if there are topics or specific areas that you want to have covered on future webinars, you know, that people could put that in the chat box as well.
Yes, please do. Okay, it looks like the majority of people have responded, and they do like that discussion time at the end of the webinar, so we'll be sure to include that this next go-around. Okay, so that is about it for our webinar. Thanks for staying with us. Even though we went over time a little bit, we really appreciate your input and the questions that you're generating, and we'll definitely pay attention to those. We'll circle back with you on any questions that maybe didn't get responses and try to provide some feedback or include some of those topics in our future webinars in the series. And so as we close out, just a reminder, you will see a survey pop up on your screen to provide us feedback about today's webinar. Please take some time to complete that for us. It just takes a minute or two, and it will really help us in making sure that future webinars are meeting your needs. Thanks so much, and have a great afternoon.